Welcome to PharmaDocs with your host, myself, Dr. Jay Resnick, and Dr. John Robertson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, good evening, John.
Hey.
Actually, it's more evening where you are than where I am. Sun's still out.
Yes.
But can you believe it's September already?
September.
Summer is going to be over.
Yes.
And we both have our birthdays in like next week and a half to 2 weeks.
That's right. We're 7 days apart, man. Can you believe it?
I know. And we have the same initials.
Same initials, too.
Yeah.
How do you like that?
Yeah, really.
And same occupation and national lecturers. And we just love doing this stuff here. Just good stuff, man. Now, I've got a little bit of an issue. We've got a little hurricane that's starting to barrel our way.
Oh, no.
Francine just hit land as a category 2. So hopefully by the time it gets up to my hometown, it's pretty much has lost all of its power and strength.
Yeah. Where's it hitting land first?
It's right around Houma, Louisiana, I believe.
Okay.
Yeah. It just came on landfall there. So
okay. Well, let's hope it peters out by the time it gets near you.
I believe it will.
Okay.
We'll be all right.
Good.
Nothing like that Katrina many years ago.
No, I
gracious.
remember that. Boy, that was, I can't remember, where was I at the time? I think I was in Florida when that hit or somewhere. And it was just looking at some of those videos and the photos. It was quite a catastrophe.
Oh, yeah.
All right. Well, let's see. So it's September 13th already, Friday the 13th. And we've got a bunch of new drugs. I think, how many were approved last month?
Gosh, we got probably around 12, 13.
Yeah, 12, 13. We're not going to cover all of them. Just to let you know, we're not going to cover them all.
Just too many.
Yeah, just too much for us and probably too much for you guys.
And like another one for AMD, macular degeneration. We've covered that as well, too. And so there's just no need to cover that at all. Yeah,
and a couple of the meds are just basically biosimilars to meds we've already covered.
That's right.
So those will be pretty quick. And
all right. So let's just go ahead and dive right on into everything, Jay, and get this.
All right. Let's
get
going. All right. So again, we want to thank our generous sponsors, iCore Connect, with their product iCore RX. So you can e-prescribe medications to your patients from any device, your computer, your iPad, your iPhone, and even your Android. And then, of course, Fortune Law.
Yep.
Who's not your typical law firm. They are there to help us keep the money that we earn and protect our assets and do some estate planning and all that. So they're at fortunelaw.com. Oh, I thought I put the address down there. And then, of course, Vesper Institute, John and my home away from home, where we're teaching an IV sedation course. In fact, we got one next month that we're teaching, and I think we have about 6 or 8 or something scheduled for 2025.
2025 is going to be very busy, Jay.
Yeah.
Very busy. And so it just shows the caliber of our program. You know, we set out to make this the very best, and we've achieved that.
I think so. And we're in October and then December also. So we'll talk more about that at the end. And Balance Pharma, who basically is going to revolutionize local anesthesia for dentistry. Because, what's the biggest complaint our patients have when we give local?
You hurt me.
It stings like hell. Yeah.
Yes.
But you can eliminate that by buffering the local anesthetic. And, I do that in, when I do facial sutures or, facial cosmetic stuff, you just draw some bicarb into your bottle of lidocaine and it buffers, but you can't do that with a dental carpule because it'll degrade over time. So you can't do it pre-mixed. It has to be mixed right before you use it.
Yeah, you have to do it right before you inject.
Yeah, and Balance Pharma has come up with a way to, they've developed a dental carpule that will do just that. It'll keep the bicarb and the lidocaine or articaine separate until you're ready to use it, and then you got instant buffered local anesthetic, no pain, and much faster onset.
It can't get here fast enough.
Yeah. Let's see. Why is this not advancing? Uh-oh. There we go.
Oh,
okay.
So our first drug, Jay, is Tecelra.
Tecelra.
Amphotericin gene.
Oh, you pronounced that. Okay.
Yes, how you like that? And
wow.
It was our first drug approved in August, and it's approved for synovial sarcoma.
It sure is. And so it's indicated for adults, not for kids that have unresectable or metastatic synovial sarcoma who've received other chemotherapy that wasn't effective. And basically, this was approved under an accelerated approval based on good response from some of the early studies. It's specific, though, for only certain kinds of synovial sarcoma. They have to be HLA O2, O1P, O2, O2P, O3P, and O6P, and positive and expressing the MAGE-A4 antigen. So that's an extremely specific,
highly specific.
Cell.
Yes.
Yeah. So, synovial sarcoma is it's a soft tissue tumor, and from the name sarcoma, you know that it's a cancerous neoplasm, and it occurs in the soft tissue of the extremities as opposed to an osteosarcoma, which occurs in bone, and it's thought to be associated with an abnormality of chromosome 18 as well as the X chromosome together. So
now what's so cool about this, Jay? This immunotherapy is made with the patient's own T cells.
Yeah.
All right. Now, so again, we're having some type of modification because it contains that MAGE-44 T cell receptor, and it recognizes and attacks the synovial sarcoma cells that express MAGE-A4.
Yeah, and it leaves the other cells alone.
Yeah.
Yeah.
I mean,
so very
cool
targeted treatment.
Targeted therapy. Yeah. How cool is that?
Pretty cool. So it's given by a single infusion. So what happens is the patient is given, goes to a facility, their healthcare facility, and they basically withdraw their blood. And then it takes about 6 weeks for the company to actually make this targeted antibody. And then the patient gets a little, a chemo to suppress like a host antigen reaction when this is infused. But it's infused, over I think about a 6-hour period, all the same day, and it's a one-time treatment, single IV dose. They also pre-med it with some antihistamine, which also helps reduce any allergic type reaction. But this, can cause a cytokine release syndrome, which can be very severe, even life-threatening, and it can also cause what's called effector cell-associated neurotoxicity syndrome, where you have severe cytopenia, increased risk of infection, secondary malignancies, hypersensitivity reactions, and potential for neurologic events in the 4 weeks following the infusion. So basically, in the 4 weeks following the infusion, these patients probably aren't coming to the dentist, but once they have
if they
passed,
had a toothache, though, Jay, they could.
Yeah, that's true. They might, and of course, you want to remove any potential source of infection. But yeah, they won't come in for anything elective, but they may come in for something emergent, and you've got to know what you're dealing with this new wonder drug. All right, so let's look at the different types of soft tissue sarcoma.
Yep.
Can occur peripheral nerves, fat tissue, joint tissue, muscle and fibrous tissue, digestive system, and blood and lymph vessels. And they're all called different things depending on where they are. So, in fat, it would be a liposarcoma. In the joints, it would be a chondrosarcoma or synovial sarcoma. In the digestive system, it would be a gastrointestinal stromal tumor, so a little different name, or fibrosarcoma or rhabdosarcoma in muscle and fibrous tissue. So it expresses itself in many different ways depending on the tissue that it affects.
All right. Verenigo.
Verenigo.
That's right. Verenigo.
And as you can tell by the last three letters, this is a immune system modulator inhibitor, and it's for the treatment of malignant glioma, which is, again, basically a nerve tumor. It affects the astrocytes and oligodendrocytes, specific ones that have a specific mutation, the IDH1 or IDH2, and this is a drug that's not given as first line. It's given for more advanced cases after surgery's been done, either complete, either biopsy for the diagnosis, subtotal resection, or a total gross resection. This is a brain tumor that comes from the glial cells, which are precursor cells in the central nervous system, and there are 4 different types. About 81% of the primary brain tumors are actually malignant.
Yep.
And the adult types are diffuse gliomas are subcategorized as astrocytomas. You probably heard of those. Then there's the IDH mutants and glioblastoma. So again, when you hear that blastoma, that is an aggressive mesodermal tissue.
Yep.
All right. Go ahead, John.
I was just going to say, and also,
I need a drink of water.
There you go. So with Verenigo, it contains veracitinib. All right. So that's a brain penetrant. It's a dual inhibitor of the mutant IDH1 and 2 enzymes.
Yeah, so it gets across the blood-brain barrier.
That's right.
And enters into the cerebral circulation.
That's right. So the enzymes help break down nutrients and generate energy for the cells and mutations associated with a variety of cancers. Now, so how this drug works, it reduces the activity of these 2 mutant enzymes.
Right.
To decrease the production of 2-hydroxyglutarate, which is involved in tumor survival and progression.
Yeah, it kind of puts the brakes on, not completely. It doesn't stop it completely, but it slows the progression and gives the patient significantly longer life expectancy. So 27, almost 28 months compared to 11 months.
And that's a lot, Jay.
Oh, yeah. That's
now I'm hoping these patients still have some form of quality of life. Okay, they can still get around and all that. Because as we know, what cancer can do to people. Right? And
in the placebo group, the cancers grew at about 14% in 6 months, whereas with Verenigo, it was only 2.5%. So it really slows it down.
Yeah.
All right. So again, this is an inhibitor, so the patient's going to be, have some immune compromise, higher risk of infection.
And now this slide here just shows our audience all the various types of gliomas, all the various types of malignant brain tumors.
Right. And there are a lot.
Yeah, there are. They're everywhere. All right. So
in the meninges within the brain itself, certain sometimes in the medulla.
Look at the brain
medulloblastoma, brainstem. Areas you wouldn't expect, but you can get tumors pretty much anywhere. Any cell that divides, something can go haywire, and so it's important to recognize all this. Great patients with brain tumors a lot of times will have symptoms such as headache, dizziness. Sometimes it'll affect the vision depending on where it is. And so those are symptoms not to be taken lightly. So if any of your patients or family ask you, oh, I had a headache and I'm a little dizzy, you got to maybe have them go see their internist so they can get an MRI and see what's going on. All right. Our next one is basically a drug that's been around for a while, but this is an extended release. So you've heard of Sinemet, which has been around, since I was in medical school.
Oh yeah.
And before that, and it's a combination of carbidopa and levodopa, but the Sinemet was taken, I think, 2 or 3 times a day, and there would be periods in between as the efficacy wanes before the next dose, where the patients would sort of be off in a sense. They're not their normal selves. The Parkinson's symptoms seem to come back until they get that next dose. But this Crexont, being an extended release capsule, keeps those blood levels up much longer, so that period of being off is much shorter. So this is indicated for the treatment of Parkinson's disease and also post-encephalitic Parkinson's symptoms that can follow carbon monoxide intoxication or even manganese intoxication in adults. And as we all know, Parkinson's is a progressive disorder of the central nervous system that affects dopamine-producing neurons in the brain that affect movement, and it's characterized by slow movements, stiffness, resting tremor, impaired balance. And we've all seen patients that have Parkinson's. Symptoms just get worse and worse over time. But hopefully with this new medication that is timed release, it'll keep them relatively active for the majority of the time. And I'm sure new drugs will be coming out that not only will affect the symptoms or improve the symptoms, but also go to the root cause, the etiology. So this it's a formulation of, as we say, carbidopa, levodopa, and it's got both immediate release granules and extended release pellets. So it consists basically released over a longer period of time. And I believe it's twice a day dosing.
Two to 4 times a day.
Yeah, 2 to 4 times a day. Okay.
Yep.
All right. So Parkinson's disease, again. Didn't see that when I first went through the slides. The symptoms of Parkinson's disease are bradykinesia, which is moving slowly, kind of mask-like.
And decreased blinking. They just have a blank stare. Like, hey, where's my ice cream?
Yeah. Exactly. GI issues, pain, difficulty walking.
The hand tremors.
Yeah.
And you'll know them by their gait. I mean, it's very short
shuffle.
steps.
They shuffle.
It's a shuffle. That's right.
Yeah, Parkinson's shuffle. So that's that new drug.
Yep.
And as far as things to look out for in your patients, let's see. I don't think there are a whole lot of drug interactions. Well, actually, no. I take that back because it affects dopamine. So anything like a midazolam or diazepam or some of the antidepressants that all affect dopamine will affect this, as well as cytochrome P450 activators may actually make this medication less efficient. All right, the next one.
Lymphir for cutaneous T-cell lymphoma.
Okay.
Check out that generic name. All right. Especially the second
the suffix,
the suffix diphthitox.
Yeah.
All right.
-CXDL, which means it's a biosimilar.
Yeah.
So
non-Hodgkin lymphoma.
Yeah. Non-Hodgkin's cutaneous cutaneous T-cell lymphoma. It's basically caused when the T cells become cancerous and they develop into skin lesions as opposed to being in the bone marrow.
Correct.
And so this agent specifically binds to the interleukin-2 receptors on the cell surface. And it's basically combined with a diphtheria toxin. So what it does is it binds the IL-2 receptor and allows the diphtheria toxin fragments to get into the cell and inhibit protein synthesis. So again, this is a very specific mechanism of action that targets both malignant T cells and malignant immunosuppressive regulatory T cells known as TREGs. And so again, you've got to, the patient's going to be somewhat immune compromised. You got to cover them with antibiotics if they're on this medication and they are at risk of developing an infection. So it's a purified formulation of.
It's been around.
It's been around since 1999 under the name Ontac, but it was actually withdrawn in 2014. But this is thought to be a little more pure and bioactive compared to the original formula. So it's back on the market for those patients who need it. Again, phase 3, which is the big study, pivotal study that showed a significant response rate of 36% of partial response and complete response in 8.7%, which is much more significant than with other medications or with placebo. And 84% of patients had a decrease in their skin tumor burden, and 12.5% saw complete clearing of the skin. So that's pretty phenomenal.
Yes, it is.
And this is, again, is an IV infusion. It's given day 1 through 5 of a 21-day cycle. So it's, they're given it every month. And again, they pre-med these patients with acetaminophen, an antihistamine, and an antiemetic because of all the potential side effects, which can include visual impairment, something called capillary leak syndrome, which can be really severe and even lead to death, infusion reactions, hepatotoxicity. This is not something you want to give to a patient who's pregnant. And I'm sure we'll know more about it as it's on the market longer. So these are some examples of this tumor.
Yep.
And it does occur not only in the skin, but also in the oral cavity. And I think the palate, hard palate, is one of the places that we see it.
That's right.
So when you see a big ulceration like that, think lymphoma. Think, a lesion like this is not going to generally be benign. And this is something that don't even bother biopsying it. Just send this patient directly to an oral surgeon to take a look at it, or if there's not an oral surgeon in your town, just to a head and neck surgeon, because they will need treatment before this gets out of control. All right. Next drug is Zernine. Now Melphaene, which we've talked about before, Opvee, which is a newer treatment for opioid overdose that, compared to naloxone, has a longer duration. Okay, so you don't have to, redose it as often if necessary. You try not to redose, because then you can put the patient into withdrawal syndrome, opioid withdrawal syndrome. But this is another brand of nalmefene that is now on the market. So, of course, it's indicated for either known or suspected opioid overdose, either by natural or synthetic opioids. So an opiate is a natural, opioid is a synthetic.
That's right.
In patients over 12 years old. And it's hard to think of 12-year-olds having opioid overdoses, but it happens. It's really, really sad.
Jay, the thing about it, okay, while we've been doing PharmaDocs, I can't tell you how many either naltrexone or naloxone or nalmefene products have come out. Why? Because the opioid crisis is not getting any better.
Yeah.
All right. Fentanyl is flooding our country from the border. Okay. And it's being cut into everything.
Yeah. And everything's being cut into it.
And I've been talking to parents in the office about, I try to stay away from opioids. I believe in non-steroidals.
Yeah, that's what I do. I haven't written an opioid prescription in, I think I've written one in the last year.
Yeah.
That's it.
And I'm just saying, this crisis is not going away.
Yeah.
And every dentist out there needs to learn how to use, whether it be an auto injector or a nasal spray.
Yeah. Which Opvee is a nasal spray.
That's right.
And this Zernine is an injection.
Right. And, this thing was approved many years ago, back in 1995, under the name Revex. And, of course, that has now been discontinued. But like Jay just said, Opvee is available, and Zernine is available. And then we're going to continue to see more and more of these come onto the market. The other thing is trying to get the OTC approval on this as well, too.
Yeah. And I'm sure we're going to see OTC versions and more versions of benzodiazepine reversal agents.
Oh yeah, this is going to be fast tracked to get OTC.
Yeah.
Because again, in our lifetime, the opioid crisis is not going away.
No, not
Now,
going
it's
away.
interesting.
In fact, we're, the experts talk about us now being in the fourth wave of the opioid crisis. So not only, the third wave was the explosion of fentanyl use, either pharmaceutical or homemade. But in this fourth wave, where you're seeing the mortality increasing, they're adding all kinds of things to fentanyl, cocaine, xylazine. I read an article, metamidine is being added to kind of increase how long it's active. And, it's obviously a major problem. And so,
well,
hopefully
the xylazine doesn't have an antagonist yet.
No.
Because
you
that
just have
is
to
a
give
veterinary
it,
drug.
right.
But they do have for dogs a reversal agent. So you're going to see probably here very soon another antagonist coming out for xylazine because like you said, Jay, you are correct. That drug is being used everywhere.
Yeah, and the really bad thing about it is it causes these incredible, huge necrotic skin ulcers that get infected. Patients end up losing limbs. I think it started, I heard, in Philadelphia, and there was a video I saw, I think, on YouTube that it's about a 5-minute video, and it just went straight to your heart about what's going on with the opioid crisis, this fourth wave, and how bad it really is. Even though, we think, we're not prescribing as many opioids, we're getting on top of this. The problem is still out there. So again, this is an auto-injector, outer thigh, through clothing if necessary. And again, additional doses can be given if necessary every 2 to 5 minutes. But again, you have to be aware. You can't just keep giving it because at one point the patient will actually go into opioid withdrawal, which can have cardiovascular effects.
They could die from that.
Yeah. So
and the dose is 1.5 milligrams of nalmefene as well too.
Yeah.
So just pay attention, everybody, to the every 2 to 5 minutes because if you're in that crisis situation, you're going to start thinking more is better if I give it quicker. And that's not the case. Like Jay said, we want to keep away from OWS, opioid withdrawal syndrome. Okay. So it's every 2 to 5 minutes. And remember, you've got to support the airway.
Yeah, I was going to say that. Yeah, because that's what leads to the demise of a lot of these patients is they are so obtunded from the drugs that they can't maintain an airway, and they end up becoming apneic and hypopneic, and then bradycardic, and then flatline. So you've got to even when you give. If you need to give a reversal agent to a patient or someone, you're giving an opioid reversal, someone you see out in the community, you've got to make sure their airway stays patent. Otherwise, you're not doing the full service.
No.
All right. So the signs and symptoms, of course, blue or purple fingernails and lips. That's from hypoxia. They're going to be unresponsive, pinpoint pupils. As I mentioned, bradycardic, slow, irregular, or no breathing, and generally kind of pale, clammy skin. So this is something that needs to be managed quickly. And again, the cyanosis and the bradycardia is due to anoxia. So you need to get the airway open at the same time you're giving the reversal agent, or even before.
And if they go pulseless, you're doing high quality CPR.
Yeah. All right.
Hey,
speaking of
Neffy.
Yeah. Yeah, it's kind of, I like that name, Neffy. It
almost sounds like that. Go ahead, I'm sorry.
Almost sounds like the name of a cartoon character.
I know. I just added that to my anaphylaxis update program as well too, because 42 million Americans, Jay, are at risk for anaphylaxis.
Yeah.
All right.
either from food allergies or some type of environmental insect bites,
medication,
and severe asthma.
Latex.
Yeah, latex, which I don't think I've seen too many latex gloves lately. I think they're pretty much phased out.
Yeah.
But so this is a way for patients who are hesitant to give themselves an injection, or family members who are hesitant to give an injection,
providers.
or that this is a nasal spray that is just effective as the injection. And so basically, alpha adrenergic, and it basically, what it does is it keeps the circulation central. So the blood's not diffusing out to the extremities. In general surgery, they used to say it was a pharmaceutical cross clamp, if you're familiar with when they do like aortic surgery or heart surgery. So this, I think, will increase the availability of a nasal spray epinephrine that will be carried by asthmatics, along with severe asthmatics, along with their inhalers, but also people who are allergic, peanut allergies, any kind of food allergies, bee sting allergies. It's going to be much more convenient for them to carry this.
Jay, there's also been question about the auto injectors, because our society has become obese, and the needle is a certain size on that auto injector, and it can't get through your clothes and the fatty layers.
Can't go deep enough.
Yeah. So
good point.
This bypasses that altogether.
Yeah.
And so but remember, we're about to look at the picture of it in just a second. So
let's see.
Again, we've already discussed that needle free.
There we go.
Yeah.
That's the picture you're talking about?
Well, yeah, that just shows everything. Anaphylaxis.
Okay.
I don't know if there was. No, I don't think.
I don't think there was another one. No.
So just remember, it looks just like the Narcan nasal spray device.
Yeah.
It's ready to go. Don't say, okay, let me just test it one time, because you just blew out your epinephrine.
Yeah. It's not like nasal quart spray where you have to prime it. It's primed and ready to go, and you get one dose out of each one. And I think it comes in a 2-pack also.
Yeah, it does.
In case you need to box of 2, in case you need to redose.
And typically, about 38% of people need another dose of epinephrine, because people think it's just going to immediately reverse the swelling and all that. It's not.
No.
All right. The swelling you see is the swelling you're going to get, and that will go down gradually. So again, we just said this about respiratory depression. Supporting the airway, you're going to have to do this also as well. Now, there's other medications you would have to give, and we'll talk about that later.
Yeah, exactly. Like antihistamines and cortisone and all kinds of things.
Yep.
All right. So, next drug is Nemluvio. Nemolizumab, which, as you can tell from the name,
we know what it is.
Yeah, exactly.
Monoclonal antibody.
Human monoclonal antibody for prurigo nodularis.
Yeah.
Which is something you may not have even heard of. It's a rare neuroimmune skin disease where you have thick nodules that are really itchy. And a lot of times patients are scratching these so much it basically erodes the top epidermal layers of skin, and then it gets infected. And this drug is a monoclonal antibody that specifically inhibits interleukin 31 or interleukin 31 cytokine signaling. And so it basically reduces the signaling that causes the cytokine release, which leads to the itch, inflammation, altered epidermal differentiation, and fibrosis. So this is a subcutaneous injection every 4 weeks in a single dose pre-filled dual chamber pen with white powder in one chamber and a clear diluent in the other, and must be reconstituted prior to administration. So this is approval was based on the Olympia 2 clinical trials that showed a 56% of the patients treated with Nemluvio and 49% in Olympia 2, at least a 4-point reduction in itch intensity at 16 weeks and clearance of skin nodules at 16 weeks.
Cool.
And
Good stuff there.
even more, as went down the line. So talk about a little bit about prurigo nodularis. Yeah. John, I'll let you do that.
Yeah, so you can just see in the picture right there, it's precipitated by, it could be by insect bite, trauma, heat, swelling, underlying folliculitis, or eczema. All right.
Yeah. Or underlying diseases like liver
Yeah.
disease, kidney disease. Yeah.
But
And
it's mostly on the arms, shoulders, and legs. And like Jay's already said, these people are going to have intense itching. And then that itching leads to the break in the mucosal surface or epithelium. And then this winds up becoming infected as well, too.
yeah. All right. Lacluse.
Yes. And look at the INIB.
Yeah. Lazertinib. So again, another immune system modulator inhibitor that is been released for treatment of non-small cell lung cancer. Go ahead, John.
Oh, I was say, so this is indicated in a combination of another drug called Rybrevant.
Yeah.
And it's a first-line treatment in adult patients with either advanced or metastatic non-small cell lung cancer, NSCLC. All right.
Yeah.
And so NSCLC, it's the most common form of lung cancer. So when you hear somebody, okay, he or she's got lung cancer, that's probably non-small cell carcinoma.
Yeah.
Okay. All right.
Yep.
And this is in about 85% of all people with lung cancer as well, too.
Yeah.
And, I can't help but think right now, Jay, I'm just thinking about everybody that vapes right now. Okay. Where are we going? Because pulmonologists have said in the next 20 years, we're going to see such a high rise in pulmonary cancers and nasopharyngeal cancers as well, too.
And not just from vaping, from the rise in cannabis use.
That's true, too, as well.
Yeah. Because even though it's natural, it's not good for you.
Yeah.
And in fact, it's bad for you.
Lacluse is a third generation TK inhibitor, tyrosine kinase inhibitor. And so you see where it inhibits right there on the EGFR exon 19, as well as exon 21. So Rybrevant, which is both EGFR and MET directed bispecific antibody that engages the immune system. So again, this is a combination drug that is multi-targeted chemotherapy-free treatment for non-small cell carcinoma.
Yeah, and very specific.
Very specific.
Yeah. And it's considered not to be chemotherapy. It's immune treatment, immunotherapy.
Yes.
All right. So yeah, it was approved by the FDA after it was demonstrated that significant improvement in disease-free or progression-free survival up to 24 months. And the mean response was about 26 months with the combination of Rybrevant with Lazcluze. And it's a pill, tablets given once a day with or without food. And it can be given in combination with the amivantamab.
Yep.
So they take them at the same time. And
they're also anticoagulated for the first 4
yeah,
months.
because it can increase clotting.
That's right.
PE, other thrombotic events, interstitial lung disease is another side effect, potentially pneumonia, severe rash.
So, Jay, these patients don't have to go down to the cancer clinic once a week and get an infusion.
Right. They just take some pills.
They take some pills.
Every day. Yep.
And like I said,
which really helps improve the quality of life because you're not stuck in the cancer clinic
center
all day long. Yeah.
That's right.
Okay.
That's huge.
So the types of non-small cell lung cancer, there are a few.
Yep.
The most common is adenocarcinoma, which usually begins in the outer regions of the lung, as opposed to a squamous cell carcinoma, which tends to cause earlier symptoms and usually begins in the bronchial tubes.
So, and think about it, about smoking and what we just talked about. That's where that's going.
Yeah, and then the large cell is another non-small cell that begins usually in the outer edges of the lung. That tends to grow rapidly, but the symptoms come usually very late.
Okay.
All right. We're at our medical emergency of the month.
I love it, man. So, okay. And this could happen at any time, at any day in the dental office. And you notice we always say that about all of our medical emergencies because none of us have a crystal ball.
Yeah.
How nice that would be, Jay, saying, you know what? I'm going to go my whole career and never have a medical emergency.
Yeah.
Don't bet on that.
Yeah, exactly.
Right?
Yeah.
And and unfortunately, some
and you could see this could happen not in your outside your office.
Yeah. And so severe allergy, facial laryngeal swelling, itching, labor breathing, cardiovascular collapse, and everybody, you've got about 3 minutes to get it right.
Yeah, and of course we're talking about anaphylaxis. So let's go through the algorithm.
Yep.
The signs and symptoms, we already mentioned the wheezing, labor breathing, stridor, cyanosis from hypoxia, swelling of the tongue and throat, which can close off the airway and lead to the cyanosis. Patients are short of breath, abdominal cramps, elevated heart rate, hypotension, and it can lead to cardiac arrest. So if it's in the dental office, obviously you're going to stop what you're doing. And then you're going to call 911 immediately, and then initiate your medical emergency plan.
And if you've got a good medical emergency plan, that person you told to call 911, you don't have to worry about that again. Because what the last thing you want to do is that find out 5 minutes into this thing, nobody's called 911.
Yeah.
And your staff members should also say, we have a suspected anaphylactic reaction at Dr. Resnick's office. Therefore, the wheels of life, that being the ambulance, can get there quickly.
Yeah, very quickly. In the meantime, you've got to start basic life support. Hopefully you've got, some exchange of oxygen and a pulse, but that could be lost at any time if you don't move quickly. So you're going to put the patient on high flow oxygen, 6 liters per minute. Nasal cannula would be recommended over a face mask because the patient's struggling to breathe. You don't want to put a mask over their face. They're not a good thing to do. And you're going to immediately, the first thing you're going to give is 0.3 milliliters of 1 to 100,000 or 1 to 1,000 epinephrine, either sub-Q, IM, or into an IV if you're running IV sedation.
Or if you've got Neffy in your office, you're going straight to the intranasal spray.
Yeah. Yeah, we don't have to get the pre-filled syringe ready.
Correct.
You can just give it right away. And then, of course, because this is, anaphylactic is an allergic type reaction, you want to get hydrocortisone in the patient, either, again, IV or IM, because it also involves histamine release. Same thing with diphenhydramine, either IM or IV, as long as they're not allergic, and just try to stabilize this patient the best you can until EMS gets there. You may end up having to, most of you don't know how to intubate a patient, but placing a laryngeal mask airway in order to maintain a patent airway so this patient can be ventilated.
Please learn how to do that. The next time your CPR instructor comes to your office, say, hey, I heard Dr. Resnick and Robertson talking about this. Teach us how to use an LMA.
Yeah, it's really simple. You just basically slide them right in. Yeah.
And then you got to support the airway until somebody gets there.
Yeah, yeah.
And like we were saying earlier when we were talking about Neffy, you're going to see swelling. And when you give that epinephrine, that swelling just doesn't go down, okay? Right. That's going to take several days while they're in the hospital.
Yeah.
All right? So that airway, and plus, look at all the drugs that Jay just mentioned. Can you draw all that up plus maintain the airway? This is why you can't do medical emergencies by yourself. You got to have a trained staff.
Exactly, your team. The other thing is because of the vasodilation that occurs when you lay the patient supine and elevate their legs above the heart so that it minimizes the circulation to the extremities and tries to keep all the blood as central as possible.
And Jay, also, patients may be on a beta blocker, which has shown to be refractory to epinephrine. Therefore, you're going to need to give them some glucagon.
Yeah.
Because the way glucagon works with the CAMP camp, if you remember that from our pharmacology.
I remember that from biochemistry.
Yeah, that will help open up channels to allow the epinephrine to work now.
Yeah.
Okay.
Yeah.
So that's why I tell everybody in my lectures, you should have a glucagon ready to go.
Yeah.
And guess what? Glucagon also has a nasal spray, and we've talked about it on this program called Basquimi.
Yeah. So glucagon is a substance that increases, or actually is used for hypoglycemic reactions.
So
to increase the amount of glucose that's released into the blood.
Gluconeogenesis. That's right.
And so
if you have a patient that goes unresponsive on you, of course you can't put a PO glucose source in their mouth now. Okay, that's why you need to have glucagon in your office because none of us know with our diabetics.
And you should also have a glucometer in your office, and everybody should know how to use it.
Yes.
All right. So,
shameless time.
Shameless plug time. We talked about PharmaDent through dentallearning.net, only $99. And then we've got some other courses, such as on dental learning, like the dental office medical emergency simulation that I did. I have my opioid course, which is a 3-hour opioid course, which satisfies pretty much every state except California. California has to be a 2-hour course, has to cover the topics they specify, and has to have a certain title. So there's a separate course, 2-hour course for those of us in California. And speaking of anaphylaxis.
Anaphylaxis update, as I mentioned earlier, we have got Neffy in there as well, too. So
good.
It's keeping everybody in your office ready to go when you get one of these life-threatening emergencies happen.
Yep. All right. So, whoops, that didn't work out right.
Come learn IV sedation with Jay and I, okay? And so we're at VesperInstitute.com. Take a look at it.
Yeah.
If you feel like you need to get your practice rejuvenated, or you feel like you're stuck in a rut, like, what else can I do to my practice to make it more enjoyable? Implement IV sedation into your practice. Right. It's a game changer for you and your patients.
And our program is a 4-phase program. It begins with 65 hours of online modules, another 24 hours in person, and I believe 60 is the minimum necessary. So we go above and beyond that.
Correct.
20 clinical cases are done. Those are actually in Cincinnati in a practice that has built itself on IV sedation. And you have one-on-one mentors with an IV sedation trained and certified general dentist.
Yep.
And then, of course, we have our ongoing support.
So I want everybody to listen to what Jay just said on the clinical. An IV certified general dentist. So those of you that are general dentists, you're probably thinking, if I go take this, I'm going to get stuck in an oral surgery clinic and all I do is start IVs and watch them take out wisdom teeth and that's it. No. You're going to be one-on-one with another fellow general dentist doing what you do every single day in your office.
Whether it's a 30-minute procedure, an hour procedure, 2-hour procedure, all those scenarios are going to be covered in your
root
clinical
canal,
experience.
Crowns, fillings, extraction, bone grafts. I mean, all of it's covered.
Yep. All right. So that kind of wraps things up for September. We'll be back October 11th with some new drugs, a new medical emergency of the month, and the same old John and Jay. So we will see you next month. Let's see where. Oh, there we go.